I know certainly we are hearing it from our members that the services that they're providing in the hospital sector, for example, let's say someone has had a stroke, and there is a need and a requirement that they be assessed within a 24-hour period, and then a certain amount of communication and swallowing therapy must be provided.
Here in your community, in Northumberland, we've had the closure of the Port Hope Hospital, the amalgamation, the creation of the hospital in Coper. Excuse me, but ongoing cuts to beds in your community, even as late as last year, there were fairly significant cuts announced in this community, also in Peterborough, of course. So as a result of those bed cuts, excuse me, Ontario has the fewest number of hospital beds of any province in Canada. We have the shortest lengths of stay. Canada has the fewest hospital beds of any developed economy in the world. And as a result of the bed closures, Ontario hospitals operate at 97.9% occupancy. And on any one day, you'll find about 700 patients languishing on stretchers in emergency departments, waiting for admission to beds in the hospitals. And as a result, there's tremendous pressure on hospital administrators, on discharge planners, on physicians to move people through, to get them out of the hospital.
And then after the election, whoever the incoming government is, we want to present our research findings to them and ask them, what is your plan? What is your strategy for going forward? How are you going to improve and increase healthcare services? And then open up beds. I mean, a 97.7 occupancy rate is very high. And the normal best practice is about 80%, 80 to 85% for other countries in the world. We're finding from our members' point of view that patients, especially the elderly, seem to be pushed out early back into their home for community care services because there is such a shortage of beds in the hospitals. And then Michael can probably speak to this better, certainly from his perspective, but we've certainly been told that the term bedwalkers, which is a terrible term to be used, that the elderly are taking up space. The problem is that there isn't facilities like long-term care facilities are being pushed into, without follow-up services. So there's this lack of rehabilitation therapy services. If they get pushed out into the community, sometimes there's transition gaps. So I know even our members have said, we don't know what happens when we discharge them out into the community, whether in fact there is a plan in place for them.
There are patients who are being discharged from hospital who still require acute care services. And we're very concerned that, especially amongst elderly patients, that they have been categorized as an age cohort, as being bedwalkers. We've had situations in Ontario. The Windsor Star reported a woman, 97 years old, dying, only weeks to live. Her family was told they had to get her out of there to a retirement home or they would be charged $600 a day. There is no way that a woman who's dying gets care in an unregulated retirement home that will allow her to die in dignity, as opposed to the palliative care unit of a hospital. In Toronto, the Toronto Star reported that a man was discharged to a retirement home. He couldn't feed himself. He died of starvation. They didn't feed him in that retirement home. Those are just examples that have been widely reported. But we believe that actually there's a pattern here. There's a pattern that the elderly in our hospitals are the group that are feeling the most pressure to leave. And we don't believe we've ever had this discussion as a society in Ontario about whether the generation that fought the Second World War should be deprived of the kind of acute care services they need at the very time that they need it most.
But often we have found too that people are sitting in hallways when in fact they should be in beds and being cared for. I mean, when we go into hospitals, we would like to think that when we get discharged we are well, or that we are at a point in our health that we can then be cared for adequately back into the community. We're also finding that there's a lot of readmission. And this is something our members have said, is that often there isn't that multidisciplinary team putting together the plan, because a patient could turn like that, and whatever risk there might be in terms of their health, that you could, in 24-hour period, change. And studies have shown that in terms of rehabilitation, once you had a stroke, that you should be at least getting 62 visits in terms of your total therapy. And they are only receiving 10. And this was a study that's been done by the Institute of Clinical Evaluative Sciences.
All of the information we have from our members is anecdotal. But what we would like to do is we'd like to invite the public to call. If they have had if their mom or their dad or their loved one has been in hospital and was discharged. I have a friend, their family dragged their father out of the hospital. He was still suffering from a drug overdose. He confused his prescription meds. There was no care plan for him. He wasn't able to take care of himself. If people have stories like that, we'd like to hear about them, and then we'd like to produce a report, excuse me, because we're concerned that when you look at the health spending plans of all three political parties going into the provincial election, they all suggest to us that there will be cutbacks, ongoing cutbacks in the hospital sector, in beds after the election. And we're going to try to step up and we'd like to come back into this community, and ideally we'd like you to meet some of these family members and talk to them yourselves about the experiences. And if, as we believe, there is a pattern that elderly people in particular are being disadvantaged, we are exploring with law firm a legal action citing discrimination in the provision of age, which would be in violation of the Canada Health Act.
Is it, once they get discharged into the community, is it on a personal support worker? Hygiene and some light housekeeping is wonderful service when you're not well, but at the same time, it's also putting the same amount of monies into your rehabilitation. And again, studies are saying that, especially for seniors, the elderly, they're not getting the rehabilitation they need. They might get 4 visits or none at all. The study that you have in your kit even talks about how 1,000 stroke patients in Ontario didn't even get any rehabilitation. For the elderly, again, it's thought they're old, they're on their way out, therefore they don't need to be rehabilitated. We'll put that funding somewhere else. And we just think it's a terrible discrimination in terms of our healthcare system. And I think that an overall plan has to be looked at.
We don't spend as much money. We spend $250 less per citizen in Ontario than any other province does on hospital care. So we haven't made the investments. I think you'll find that's the same in long-term care. So we have a shortage of acute care beds. We have a shortage of long-term care beds. And you're absolutely right about the nuclear family and there are a lot of seniors who are facing health challenges without family supports, and they shouldn't need to have an advocate and a crusader by their bedside. They should have a system that that gives them the care they deserve. There are elements that are driving up healthcare spending, like the way we pay the physicians with the fee-for-service billing system. If you take a look at how much doctor salaries have increased in the last 5 years alone, you'd be staggered. They're huge jumps. The drugs, the restoration of the drug patent legislation that Brian Mulroney interfered with would have an enormous impact on the drug costs for citizens, but also for the provincial government. And the higher costs of private involvement in the delivery of care. Ontario's building 22 private-public partnership hospitals. The Conservative government in Britain has just done an analysis of their P3 projects and decided that they shouldn't do any more because they're a horrible waste of taxpayers' money. We're online to build 22 of those. Should we? I mean, there are areas of investment, I think, that could be made if we dared to tackle some of the things that really are pushing up healthcare spending. But all the pressure's always on the hospitals. I don't think the doctors, the drug companies, or private interests ever feel that pressure. I think it's government's responsibility, I'm talking about the plan again, to ensure that there is an inflationary component to that. Again, when you look at the baby boomer balloon, are they preparing for that? Is that plan in place? It doesn't necessarily mean more,
it means perhaps then just looking at a strategy as to how can we use our current dollars with an inflation in it. I mean, I think even the current system talks about a 3% increase anyway, and there should be. Where's it? So it's going to have to come from somewhere. That's if we as a society to continue to value our healthcare system, which I think we all do, and we want to all be in partnership to making sure that it's going to be there for us when we need it. For us, over the last at least 5 years, we've not seen any increases, and yet we know that the demand and the pressures are growing. So in our view, that's really a decrease. It's a decrease in service. And certainly from my perspective, I'm part of that baby boomer generation, and there's a big balloon coming. And is there a plan in place for what happens? Let's hope none of us will ever end up in that situation.